Welcome to QAxon. So in this video, you will learn about Myasthenia gravis. Under this topic, I will largely be covering the basis of this disease. Since this is a disease of the neuromuscular junction, we will closely examine the basis of the symptoms as well as the basis of treatment. So here we go. So what is Myasthenia gravis? Fortunately, Myasthenia gravis is a very rare disorder. It affects the neuromuscular junction of skeletal muscle. To be more specific, it affects the nicotinic receptors. So this is an autoimmune disease, and what basically happens is that if this is the neuromuscular junction, and these are the nicotinic receptors to which acetylcholine normally binds, the autoantibodies in Myasthenia gravis go and occupy these sites. They bind to the nicotinic receptor, and therefore acetylcholine cannot bind, and this leads to skeletal muscle weakness. Now, the weakness of Myasthenia gravis is rather characteristic. It is not a continuous sort of muscle weakness. So let's examine what really happens in Myasthenia gravis. So if this is the axon terminal, and this is the motor end plate, and these are the nicotinic receptors. Now we know that in the patient with Myasthenia gravis, the nicotinic receptors are already occupied by autoantibodies. Now, when this individual wishes to contract this muscle, he is not able to do so because these receptors are occupied by the autoantibodies and acetylcholine cannot bind to them. So the individual puts more and more mental effort, and each time there is release of more and more acetylcholine, and therefore acetylcholine goes on building up in the cleft. At one point, the concentration of acetylcholine is so high that it is able to displace the autoantibody and go and bind to the receptor. And this is why the weakness is not evident at this stage. But what would happen if this muscle is repeatedly used? So each time a large quantity of acetylcholine gets used up. So after a few efforts, the acetylcholine stores here at the axon terminal would get exhausted. And that is when this patient displays weakness. So it is not a continuous sort of weakness. So initially, the patient is able to contract the muscle because of release of more and more acetylcholine. But with repeated use of the muscle, the acetylcholine stores are depleted, and that is when the patient manifests fatigue or weakness. Now, the most common type of myasthenia that we encounter is the ocular form, characterized by ptosis, which is drooping of the upper eyelid, and diplopia, which is double vision. Now, these symptoms are worse towards the end of the day because it is with repetitive use that fatigue sets in. So how is Myasthenia gravis treated? Conventionally, there are three important modalities of treatment, but now we have a lot of newer therapeutic options. Some patients with Myasthenia gravis may have a thymoma or thymic hyperplasia accompanying the symptoms of Myasthenia gravis. Now, this thymoma or thymic hyperplasia is believed to play a role in the autoimmunity. So thymectomy could help these patients. So we resort to thymectomy if these patients can tolerate surgery. The other procedure we often do, especially for patients presenting with a crisis, is plasmapheresis, wherein we take out the blood from the patient. We separate out the plasma and the cells, and we know that the plasma would contain the autoantibodies. So that is removed and the cells are infused back into the patient. This provides relief, at least for some duration of time. So plasmapheresis is the second modality of treatment, and symptomatic treatment can be provided by drugs such as neostigmine and physostigmine. Now, how do these drugs act? So these drugs are actually choline esterase inhibitors. Now we know that there is an enzyme called choline esterase at the neuromuscular junction. Now normally this enzyme degrades any free acetylcholine present in this junction. And that is what causes the bound acetylcholine to detach from the nicotinic receptors. So if we block this enzyme using neostigmine or physostigmine, then the free acetylcholine is not degraded. So acetylcholine concentration here in the cleft is very high. So once you have a high acetylcholine concentration in the cleft, it can displace the autoantibodies bound to the nicotinic receptor. So this is how neostigmine and physostigmine help. They help in building high concentrations of acetylcholine in the neuromuscular junction. There is yet another entity called the Lambert-Eaton syndrome, which shares some similarities with Myasthenia gravis. Here also, the weakness of skeletal muscle is very similar to that of Myasthenia gravis. Now, what is different here is that the presynaptic voltage-gated calcium channels are affected in this disorder. This is also autoimmune, but it is not the nicotinic receptor which is the target. The voltage-gated calcium channels in the presynaptic terminal are the target. And therefore, the neurotransmitter, that is acetylcholine, is not released because that depends on calcium ions. Therefore, there is a failure of neuromuscular transmission and the symptoms mimic that of Myasthenia gravis. So that brings us to the end of this session. Thank you.